Good evening, friends. Thank you, Shailaja ma'am, for inviting me for this talk today. So, as ma'am has already discussed about a metabolic syndrome patient that we see in our day-to-day clinics. So, my talk for today is about something about usage of SGLT2 inhibitors in heart failure across injection fraction. We all know that once a diabetic, always a diabetic, once a hypertensive, always a hypertensive. Similarly, is going to be heart failure patient for lifelong and is going to move around the spectrum of ejection fraction, reduced ejection fraction to mid-range ejection fraction to preserved ejection fraction and vice versa. We have been targeting our patients mostly with heart ejection fraction till today. Why? Because we considered those patients to have higher mortality, higher hospital admissions, had better drugs to treat them. We had completely neglected heart failure with preserved ejection fraction till today, probably because we thought that these patients may not be having your hospital admissions, or more or less, even if we diagnose them, we didn't add specific drugs to treat them, and that's why it was very much till recently where data has given us sufficient evidence that there are good drugs which can actually have better heart failure with preserved ejection fraction. So let me start with few basics about heart failure terminologies which are present today. It is now divided into three different types. One is always heart failure with reduced ejection fraction or FREF, where with typical signs and symptoms of heart failure will have an ejection fraction of less than 40%. Then there is the other extreme with signs and symptoms of heart failure, recommend echo fraction of more than 50% or even sometimes more than 60%. There is a mid-range variety where the 40 to 50. These are usually patients who are either in a worsening condition, maybe have recently suffered from an acute coronary, or they are improving from FREF towards HFpEF. So there are few factors which are associated with either clinical progression in these patients. Factors associated with good recovery are patients having heart failure in a younger age group, in females presented with a lower heart failure severity, a shorter heart failure duration, or having fewer comorbidities. On the other hand, who are likely to worsen from HFpEF to HFrEF would be those having mainly major comorbidities like diabetes, presence of coronary artery disease, of specialized heart failure follow, and higher NT-proBNP levels. And surprisingly, data for hospital readmissions or all-cause readmissions, or even for that matter all-cause death, and we compare the three types of heart, we can see that the heart failure readmissions are close to 50% in HFrEF patients, but even in HFpEF patients, the about almost 40%. So that's quite high. Previously, we thought that these patients may not need recurrent hospitalizations, but even in HFpEF and heart failure with mid-range, heart failure readmission rates are close to 40 to 45%. Similarly, all-cause readmission rates are also almost equivalent. If you look at the all-cause death, that is a big surprise that even the mortality statistics are similar in ejection fraction as compared to reduced ejection fraction. So we definitely can't neglect our heart failure patients who have an ejection fraction of more than, and that's why nowadays we say that any heart failure is having equal chances of hospital readmissions or cardiovascular mortality irrespective of ejection fraction. Heart failure is diagnosed, forget about looking at the ejection fraction, treat him with all possible medications, lifestyle interventions, and correction of comorbidities. Earlier decades, the prevalence of heart failure with preserved ejection fraction was low, but if you look at the current data, the FPF are gradually rising. Now it doesn't mean that FRF is reducing and FPF is rising, but out of suppose 100 patients of heart failure are being, the prevalence of FPF among those heart failure patients is increasing, even though the absolute numbers are increasing all categories. For this could be obviously with the rapidly aging global population because of better treatment availabilities and more incidence of like diabetes, hypertension and obesity. That's why the incidence and prevalence of FPF is also rising. We all know that the heart failure into 4 different stages. Technically stage A, even if by definition they are not actually heart failure patients, but they are actually at higher risk of developing HF in future. We considered as those having diabetes, hypertension, dyslipidemia, a positive family history of heart disease and heart failure. Also stage B, wherein there is onset disease like the presence of first acute coronary syndrome, but still they may not be having symptoms or signs of heart failure. Now these are the 2 stages where actually preventive therapies so as to prevent these patients from progressing to stage C or stage T heart failure. Stage C is where the patients are symptomatic previously or ongoing symptoms of heart failure along with presence of structural and or functional heart disease. And lastly, refractory heart failure specialized treatments like interventions or need recurrent hospitalizations. But with every hospitalization, after these patients keep on worsening in terms of recurrence of symptoms as well as increase in the mortality and reduction in the quality of life. The mortality risk in heart failure is an urgent basis. That's why we can see that in hospital mortality in HF is very high after acute decompensation, and as time progresses over a period of 5 years, almost 50% of the patients are likely to succumb from heart failure. Now, goals of therapy in heart failure are mainly 3 aims. One is obviously reduction in mortality. Second is prevention of recurrent hospital due to worsening of heart failure. And lastly, but from patient's perspective, this is the most important, that is improvement in clinical, the functional capacity and quality of life. So what do the guidelines recommend? The ESC 2021 heart failure guidelines suggested that is one of the important treatments amongst others including beta blocker, ACE or ARNI, MRA and a loop diuretic for fluid retention. 2022 HFA guidelines suggested again SGLT2 inhibitor as one of the 4 pillars amongst the other 4 pillars in the treatment of HFrEF, mainly heart failure with reduced ejection fraction. The 2023 AC guidelines for HFpEF were published for the was a guideline directed medical therapy for heart failure with preserved ejection fraction. Till now the guidelines didn't recommend any class 1 therapy for HFpEF, but this was when after SGLT2 trials gave sufficient evidence that SGLT2 trials can be considered as a class 1A indication, and that's the only drug which is with the class 1A level in the treatment of HFpEF patients. Even in the 2023 ESC update, it was shown and SGLT2 inhibitors were the only class of drugs which should and can be given in all HFpEF patients. Beyond that, the other class of MRA and beta blocker may be considered with a class 2B indication in such patients. So, how does actually SGLT patients help in our heart failure patients? So, as ma'am showed one of the slides wherein it was shown that SGLT2 inhibitors does help in reducing fluid volume. and that is one of the most important aspects where it helps when SGLT2 inhibitors are started during the index hospitalization of heart failure. It can help in reducing the early pulmonary edema in ADHF patients where we are not able to initiate other goal-directed medical therapies, but can be started immediately after admission for heart failure, and probably one of the mechanisms where it helps in that stage is by reduction in the interstitial fluid volume. Apart from helps in the long term with amelioration of endothelial dysfunction, decreased oxidative stress, downregulation of systemic inflammation, it improves heart pump energetics, another improvement in the early stages, reduce sympathetic activity, increase diuresis. By inhibition of sodium hydrogen exchange, it also causes increased erythropoiesis. And with all of that, in the long run, it will help in amelioration of organ damage induced by heart failure, CKD, as well as infections, and ultimately will lead to improved survival, which has also been clearly shown in evidence by improved CV deaths and mortality for heart failure patients. So, what is the evidence with DAPA to support these guideline recommendations? There were mainly two trials, HF trial for HFrEF patients and the DELIVER trial for HFpEF patients. In Paradigm HF as well as DAPA HF, when SGLT2 was initiated along with the other goal-directed medical therapies as an add-on drug to the first three drugs, it had showed improved survival and other benefits as compared to the three drugs alone. So this was the DAPA HF trial where mainly the heart failure with reduced ejection fraction having an EF of less than 40% were in. It was combined in a 1:1 randomization against placebo. So if we look at the statistics, there was a statistic as compared to the placebo right from day 28 after its initiation, and it showed a significant 26% in CV death or worsening of heart failure. This was the pattern that I was talking, that when SGLT2 is added to other three drugs like ARNI, beta blocker and MRA, it showed a significant drastic improvement in CV mortality as well as HF hospitalizations. So this was again new breakthrough in the management of HFpEF, where conventionally only ACE, ARBs or beta blockers were used initially. So these trials of SGLT2 inhibitors which had showed a significant impact in heart failure patients. Then came the DELIVER trial where heart failure with fraction patients were included. Again, the DAPA was compared against placebo. The primary endpoint was the time to first occurrence of any CV death or worsening heart failure patients. This was again a multi-center randomized control trial. The patients were quite patients up to 72 years were included in this patient. There were a lot of comorbidities associated, including diabetes, obesity, hypertension, disease. Again, here we can see that in fact usage of dapagliflozin showed statistically significant results, and the results as early as day 13. In HFrEF, the results were seen as early as day 28, but in HFpEF, the results were as day 13 of initiation. And again, there was a 18% relative risk reduction in the composite endpoints as compared to placebo. Now, if you look at the various subgroups, irrespective of the ethnicity, age, or the comorbidities, everywhere DAPA showed to be as compared to placebo when conventional standard of care was used in all these patients. Again, if you look at the safety outcomes, the adverse effects were similar. So, evidence of DAPA across the full EF range using pooled analysis of DAPA HF and DELIVER was also published. The purpose of this particular analysis was to examine the effect of DAPA across all spectrum of LVF, given the attenuation with higher LVF in other HF medication trials. For example, in empagliflozin, it was shown that when the ejection fraction was more than 60%, currently could not show mortality benefits. But whereas in DELIVER trial, that particular deviation was also addressed, and even in those patients who had of more than 60%, despite having heart failure symptoms or elevated BNP, DAPA showed a significant improvement in CV mortality especially. The combined effect of DAPA-HF and DELIVER together, what DELIVER adds to the FF management compared to other SGLT2, as we said, that in those patients having EF of more than 60%, the total hospitalization for heart failure and CV deaths were still better compared to placebo, but in EMPA somehow failed to show that benefit when the EF was above 60%. I'll skip through these statistical slides. Again, there was another trial with heart failure fraction. This was something new terminology, where patients who were initially in the HFrEF category and with appropriate treatment improved to a better, and now they were above 40%, then they were called as heart failure with improved ejection fraction. Even in such patients, it was shown that continuation of 4 pillars of GDMT, including SGLT2, would definitely help in reduction in recurrent heart failure hospitalizations. Now, this particular analysis was specific to SGLT2 inhibitors, where those patients who improved EF to more than 40%, continuation of SGLT2 patients also showed significant improvement as compared to stopping SGLT2 inhibitors in the long run. So to summarize, mortality was significant in DAPA-HF as well as the DELIVER pooled analysis, the entire spectrum, and showed that CV death as well as heart failure hospitalizations does reduce significantly as against placebo. Again, this was not a head-to-head comparison with EMPA, but if we compare the different trials, then different trials would show different outcomes. But ultimately what we need to understand is that in all spectrum patients, irrespective of ejection fraction, we should initiate and continue SGLT2 inhibitors as long as the patients can take it. So, advantages of SGLT2 inhibitors are: it is a single dose, no dose titration is needed, one pill once per day, substantially improves survival as well as prevents hospitalization, improves the quality of life as well as functional status. The benefits appear rapidly within 18 to 28 days of initiation, exceptionally and safe, does not lower blood pressure or does so very minimally, hence very safe again to give in acute heart failure patients. No adverse renal effects, and instead preserves kidney and prevents dialysis in worsening kidney failure patients as well. So again, the debate with original versus, but I usually give options to my patients. This is the imported original medication versus the available generics. Those who can afford definitely use the original one, because in my experience I found to give it better weight control as well as A1C reduction. But for those who can't afford, something is definitely better than nothing. Hence we shouldn't divide them from using generics instead of not using anything. So with that over here, we can have the discussion.